Welcome to the deep dive. If you're prepping for the MSRA and Iron Deficiency Anemia or IDA is on your revision list, well, you've come to the right place.
Absolutely.
Think of this as your focused session. We're pulling out just the essentials you need for IDEA.
Exactly. We've done the legwork, sifted through the sources to give you a really clear, hopefully memorable overview for the exam.
Great. So let's jump straight in. What actually is ID?
Simply put, it's anemia, so low red blood cells, low hemoglobin, specifically because there isn't enough iron in the body.
And it's common, right? Like really common.
Oh, incredibly. It's the most common cause of anemia across the globe. And it hits certain groups, harder young kids, women of childbearing age. The stats say maybe 1 in 5 women.
1 in 5. Wow, that's significant.
It really is. So our mission today is basically to extract that high-yield info for your revision. We'll try and drop in some memory aids, too, just to make it stick.
Perfect. Let's nail the definition first then. Low red cells, low hemoglobin, due to lack of iron, most common type worldwide.
Yep. And the WHO has specific numbers. Remember, HB less than 130 grams per liter for men 15 and over,
Okay, 130 for men.
and less than 120 grams per liter for non-pregnant women, same age group.
120 for women. Got it. Those numbers feel important for the exam.
Definitely worth remembering. Okay, so why does it happen? The causes, or etiology,
Right.
we can think of it in maybe 3 main buckets: reduced intake, increased requirements, and iron loss.
Okay, let's tackle iron loss first. Excessive blood loss. That sounds like a big one.
It often is. For premenopausal women, you're thinking heavy periods menorrhagia.
Right.
But for men and postmenopausal women, if you suspect IDA, you must think about GI bleeding, gastrointestinal.
Okay, GI bleed is top of the list there.
Absolutely. And don't forget, in some parts of the world, things like hookworm or schistosomiasis, those tropical gut infections, can cause significant blood loss too.
Good point. And within GI bleeding, what are the common culprits we should know?
Well, there's quite a list. Think about NSAID, used really common cause of irritation. GI cancers are a major concern, obviously. Inflammatory bowel disease like Crohn's or UC.
Ulcers.
Peptic ulcers, definitely. Gastric or duodenal. Also postpartum hemorrhage. Colonic cancer, especially in older people.
It's a broad differential just within GI bleeding.
It is. And then less common things like esophageal varices, angiodysplasia, even hemorrhoids sometimes, renal tract cancers, post-surgery, even donating blood frequently.
Wow. Okay, so key takeaway. Always consider blood loss, especially GI loss in men and postmenopausal women.
Exactly. Now, what about the second bucket? Inadequate dietary intake.
This seems more obvious, maybe. Not eating enough iron.
Pretty much. Vegans and vegetarians might need to be more mindful, although plenty of plant sources exist, like leafy grains.
Right. Non-heme iron.
Precisely. Also, think about growing kids. They need more. And sometimes the elderly, if their diet is poor or restricted.
So it's not just if you eat iron, but maybe how much you can use.
That leads perfectly into the next point. Poor intestinal absorption. You have to be able to absorb the iron you eat.
Makes sense. What stops absorption?
Well, iron's best absorbed in its ferrous state.
Mm-hmm.
So things that interfere, certain drugs, antacids, definitely. Stomach pH matters.
Oh, right.
Also, things in food itself, phytates, polyphenols, like in tea and coffee. Calcium can interfere too.
In certain medical conditions?
Yes. Celiac disease is a big one. Damages the gut lining. Having had stomach surgery, a gastrectomy, even H. pylori infection in the stomach.
So lots of potential blockers. Is there anything that helps absorption?
Yes. Heme iron, the type found in meat, fish, poultry that's generally absorbed much better. And vitamin C helps with non-heme iron absorption.
Good tip. Meat helps absorb. Okay, and the last category, increased iron requirements.
It's mainly about specific life stages. Rapid growth spurts in kids. And pregnancy is a classic example. The mother's blood volume expands hugely. Plus, the baby needs iron. It can lead to a sort of dilution effect, too.
Right, so growth and pregnancy are key times for increased need. Okay, so if we were trying a quick mnemonic for causes, maybe like BO, blood loss, intake low, lack of absorption, plus the G for growth and P for pregnancy. BIL-GP.
BIL-GP. Yeah, if that works for you, absolutely. Whatever helps it stick. It covers the main areas.
Okay, cool. Now, linking causes to risk factors, who's most likely to get IDA?
Well, it follows directly from the causes, really. Poor diet is a big risk factor.
Sure.
Any kind of chronic blood loss, heavy periods, slow GI bleed, that's a major risk.
Right.
And then conditions that mess with absorption. So celiac disease, again, IBD, those put you at higher risk.
Makes total sense. Okay, let's zoom in a bit. Pathophysiology. What's happening inside the body at the cell level?
So iron is absolutely crucial for making hemoglobin. That's the protein in red blood cells that carries oxygen.
The oxygen carrier?
Exactly. No iron, or not enough iron, means you can't make enough hemoglobin. This forces the body to produce red blood cells that are smaller than usual. That's microcytic.
Microcytic small cells.
And paler than usual hypochromic, because they lack that red hemoglobin pigment. Think small and pale.
Okay. Small and pale because there's no iron for the hemoglobin.
Precisely. And because they lack hemoglobin, they just can't carry oxygen as efficiently to the tissues.
And does the body try to compensate somehow?
It does. It senses the low oxygen and tries to ramp up red blood cell production. But because the raw material, the iron, is missing, the new cells it makes are also small and pale.
Ah, so you get more cells, but they're still deficient.
Well, you might initially see increased production markers, but ultimately the overall count can drop too. But the key feature on the blood test is that low mean corpuscular volume, the MCV. It reflects those smaller cells.
Low MCV.
Yep.
Got it. So when we see that low MCV, that microcytic picture, what else could it be? What's the differential diagnosis?
Good question. It's not always IDA. Thalassemia is a really important one. It's genetic, affects hemoglobin production, also gives microcytic anemia.
How do you tell them apart?
Often, in thalassemia, the red cell count itself might be normal or even high, unlike IDA where it can be low. And iron studies, particularly ferritin, are key. Ferritin is usually normal or high in thalassemia.
Okay, ferritin is the decider there. What else?
Anemia of chronic disease, things like chronic inflammation, infection, malignancy. Sometimes that could be microcytic or normocytic. But again, ferritin is usually normal or high because it's an acute phase reactant. Low ferritin really points strongly towards IDA.
Right, low ferritin, IDA usually. Are there other deficiencies to consider?
Yes, but B12 and folate deficiency typically cause macrocytic anemia, big cells, high MCV, though you can have mixed pictures, which complicates things.
Yeah. Anything else for microcytic?
Less common things like sideroblastic anemia, lead poisoning, they usually have other clues, though.
Okay, so low MCV is a hint, but check the ferritin in the whole picture. Let's talk numbers again. Epidemiology. How common is it in the UK?
In the UK, figures suggest around 2 to 5% of adult men, but it's higher in women, maybe 8–12% of adult women.
That's quite a difference.
It is, and certain groups are higher risk. Pregnant women, young kids, people with GI issues. Globally, as we said, it's huge. Maybe 500 million people affected. Most common anemia worldwide.
500 million, wow.
Yeah, even in developed countries, the rates are similar to the UK. And it's really serious in young children and during pregnancy because it can affect development. Premenopausal women are just inherently at higher risk because of periods in pregnancy.
Okay, underscores the importance. Now, how does it actually look in a patient? Clinical features, symptoms.
Often quite nonspecific, unfortunately. Fatigue is huge.
Okay.
Weakness, feeling short of breath when they exert themselves, palpitations, looking pale, the pallor.
General symptoms of anemia, really.
Pretty much. But there are some more classic signs associated with iron deficiency specifically.
Ah, like the nails.
Exactly. Spoon-shaped nails, koilonychia, that's a
Wow.
classic, though not always present. You might also see faint lines, longitudinal ridges.
Koilonychia, spoon nails.
Yeah.
What else?
Hair loss can happen. A smooth, sore, red tongue that's atrophic glossitis. Sometimes cracks at the corners of the mouth, angular stomatitis or chylitis. And rarely, postcricoid webs in the esophagus.
Spoon nails and smooth tongue sound like good ones to remember.
Definitely.
And I guess the symptoms depend on how bad the anemia is.
Absolutely. Mild IDEA might have few symptoms, maybe just picked up on a blood test. More severe cases might have dizziness, headaches, cold hands and feet, brittle nails. The tongue might be quite swollen and sore.
Can it get really serious?
Yes, very severe anemia can cause shortness of breath even when resting. Angina-like chest pain, ankle swelling signs, the heart is struggling.
Okay. And on examination, what are we looking for?
Pallor, definitely check conjunctiva, palms. Look closely at the nails for koilonychia. Check the mouth for angular chylitis. Look at the tongue for atrophic glossitis. In severe cases, listen for a fast heart rate, tachycardia, maybe signs of heart enlargement or even failure.
Right, so a good clinical exam is still vital. Okay, we suspect IDA based on symptoms and signs. How do we confirm it? Investigations.
Number 1 is the full blood count, FBC. That gives you the HB, the red cell count, and those crucial indices MCV and MCH. Corpuscular hemoglobin, both typically low in IDA.
Low HB, low MCV, low MCH. What next?
Check the iron stores directly. Serum ferritin level, that's usually the best initial test. Low ferritin is the hallmark of IDA.
Low ferritin seals the deal mostly.
Pretty much. You can also check serum iron, which will be low, and total iron binding capacity, or TIBC. That's often high because the body makes more transferrin protein trying to grab any available iron.
Low iron, high TIBC. Okay. Anything else?
A blood film can be useful. The lab might report anisocytosis variation in cell size and poikilocytosis variation in shape. You see those small, pale cells.
Okay. And do we need more tests after confirming IDA?
Often, yes, because you need to find the cause. Why are they deficient?
Yeah.
So depending on who the patient is, their age, symptoms, risk, you might need urine tests, maybe coeliac screening blood tests, and very importantly, if you suspect GI blood loss.
Endoscopy, colonoscopy.
Exactly. Upper or lower GI investigations might be needed, especially crucial in men and postmenopausal women with unexplained ID. You have to rule out malignancy.
Right. Diagnose with bloods, find the cause. Got it. So we've diagnosed IDA, maybe found the cause. Management, what do we do?
2 key goals. 1, treat the underlying cause. Can't stress that enough. If it's GI bleeding, you need to address that. Rule out cancer.
Crucial first step.
Second goal, replace the iron.
How? Tablets.
Usual, yes.
Or
Oral iron supplementation. Ferrous sulfate is common. The really important bit is telling patients they need to take it for about 3 months after their hemoglobin is back to normal.
3 months after? Why so long?
To rebuild the body's iron stores, the ferritin levels. Otherwise, the anemia can just come back quickly.
Okay, good point. What about side effects? People complain about iron tablets.
You do. Nausea, tummy pain, constipation is common, sometimes diarrhea. Black stools are normal. Warn them about that. Taking it with food can sometimes help the stomach upset, but might reduce absorption a bit. It's a balance.
And diet. Can you just eat more iron?
Dietary advice is important. Dark leafy greens, meat, fortified cereals. But for established idea, diet alone usually isn't enough to fix it quickly. It's more for prevention and long-term maintenance. Adding vitamin C with plant-based iron helps absorption.
Okay. What if someone really can't tolerate the tablets or the anemia is severe?
Then intravenous or IV iron is an option. He gets the iron in directly, bypasses the gut, used for intolerance, poor absorption, or when you need to raise levels fast.
Okay. When do we need to get specialists involved? Referral to secondary care.
Right. Urgent referral, think 2-week wait if you suspect cancer, like a new GI bleed symptom in an older person.
Makes sense.
Definitely refer men and postmenopausal women with confirmed IDA to gastroenterology for investigation, usually. Also, anyone with really profound anemia.
What about women's health?
Yes, refer to gynecology if menorrhagia isn't responding to initial treatment or for any postmenopausal bleeding.
Any other reasons?
Positive coeliac test needs follow-up. Severe anemia causing heart failure symptoms needs urgent attention, maybe hospital admission. And if someone just isn't responding to oral iron or can't take it, they need specialist input, maybe for IV iron or further investigation.
Okay, clear referral criteria. Once treatment starts, how do we track progress? Monitoring and follow-up.
Check that FBC again after about 2 to 4 weeks. You want to see the hemoglobin starting to rise.
What's a good response?
Generally, you're looking for an increase of at least 2 GDL or 20 GL in that 2-4 week period. If you see that, great. Continue for the full 3 months post-normalization and check again then.
And if the HB doesn't rise enough?
Then you need to troubleshoot. Are they actually taking the tablets? Is it the right dose? Is there ongoing bleeding you missed? Is the diagnosis correct? Could it be malabsorption? Maybe you need to try a different formulation or consider IV iron. If the response is poor, definitely consider referring or seeking advice.
Okay, so recheck FBC at 2-4 weeks. Aim for 2 GDL rise, reassess if not. And maybe transfusion in severe cases?
Yes. Transfusion is reserved for severe symptomatic anemia or where a very rapid rise is needed, but it doesn't fix the underlying iron deficiency.
Right, it's a temporary fix for the hemoglobin. Okay, looking ahead, what's the usual prognosis?
Generally excellent, provided the underlying cause is treated and the patient takes the iron replacement correctly. Symptoms improve, blood counts normalize.
But it can come back?
Yes, if the cause persists, like untreated heavy periods or coeliac disease, or if they don't complete the treatment to rebuild stores, untreated long-term IDA can cause persistent fatigue, affect concentration and work performance, make you more prone to infections. So adherence and follow-up matter.
Okay. And any specific complications to be aware of?
In children, severe or prolonged IDA can impact physical growth and, importantly, cognitive development. That's a major concern.
Right, development in kids.
Generally, as mentioned, increased susceptibility to infections, and in severe cases, especially with underlying heart issues, it can strain the heart, leading to arrhythmias or even heart failure.
So treating it isn't just about feeling less tired, it's preventing some potentially serious issues.
Absolutely. Early diagnosis, finding the cause, and effective treatment are key.
Well, this has been incredibly thorough, a real deep dive into IDEA. I think the main takeaway for me is yes, it's common. Yes, it's usually treatable with iron, but you must find out why they're deficient, especially ruling out serious causes.
Exactly that. It's about connecting the dots, the definition, causes, the pathophysiology leading to those clinical features and investigation results, and then targeted management and follow-up, always keeping the underlying cause in mind.
We really hope this has helped consolidate things for your MSRA revision. It's a topic that definitely comes up. Now, just as a final thought to leave you with, considering all those diverse causes we talked about, what do you think might be the single most challenging aspect when you're faced with diagnosing and managing a specific IDA patient in practice? Something to mull over.
A very relevant clinical question indeed.
And with that, don't forget to check out passthemsra.com and framesra.com for loads more MSRA revision resources. Thanks so much for joining us on the deep dive.